Small bowel obstruction. Pathophysiology. Intestinal contents, fluid and gas accumulate above the intestinal obstruction. The abdominal distension and retention of fluid reduce the absorption of fluids and stimulate more gastric secretion. With increasing distension, pressure within the intestinal lumen increases, causing a decrease in venous and arteriolar capillary pressure. This causes edema, congestion, necrosis, and eventual rupture of or perforation of the intestinal wall with resultant peritonitis. Reflux vomiting may be caused by abdominal distension. Vomiting results in a loss of hydration ions and potassium from the stomach, leading to a reduction of chlorides and potassium in the blood and to metabolic alkalosis. Dehydration and acidosis develop from loss of water and sodium. With acute fluid losses, hypovolemic shock may occur. Three causes of intestinal obstruction. Number 1, intussusception, invagination or shortening of the colon caused by the movement of one segment of bowel into another. Number 2, valvulus of the sigmoid colon. The twist is counterclockwise in most cases. Third one, hernia, inguinal. The sac of the hernia is a continuation of the peritoneum of the abdomen. The hernial contents or intestine, omentum or other abdominal contents, they pass through the hernial opening into the hernial sac. Clinical manifestations. The initial symptom is usually crampy pain that is wave-like and colicky. The patient may pass blood and mucus but no fecal matter and no flatus. Vomiting occurs. If the obstruction is complete, the peristaltic waves initially become extremely vigorous and eventually assume a reverse direction with a intestinal contents propelled toward the mouth instead of toward the rectum. If the obstruction is in the ileum, fecal vomiting takes place. First, the patient vomits the stomach contents, then the bile stain contents of the duodenum and the jejunum, and finally, with each paroxysm of pain, the darker fecal-like contents of the ileum. The unmistakable signs of dehydration become evident: intense thirst, drowsiness, generalized malaise, aching, and a parched tongue and mucous membranes. The abdomen becomes distended. The lower the obstruction in the GI tract, the more marked the abdominal distension. If the obstruction continues uncorrected, hypovolemic shock occurs from dehydration and loss of plasma volume. Assessment and diagnostic findings. Diagnosis is based on the symptoms described previously and on X-ray findings. Abdominal X-ray studies show abnormal quantities of gas, fluid, or both in the bowel. Laboratory studies, example, electrolyte studies and a complete blood cell count, reveal a picture of dehydration, loss of plasma volume, and possible infection. Medical management, decompression of the bowel through a nasogastric or small bowel tube is successful in most cases. When the bowel is completely obstructed, possibility of strangulation warrants surgical intervention. Before surgery, intravenous therapy is necessary to replace the depleted water, sodium, chloride, and potassium. The surgical treatment of intestinal obstruction depends largely on the cause of the obstruction. In the most common causes of obstruction, such as hernia and adhesions, the surgical procedure involves repairing the hernia or dividing the adhesion into which the intestine is attached. In some instances, the portion of affected bowel may be removed and an anastomosis performed. The complexity of the surgical procedure for intestinal obstruction depends on the duration of the obstruction and the condition of the intestine. Nursing management of the non-surgical patient with a small bowel obstruction includes maintaining the function of the nasogastric tube, measuring the nasogastric output, assessing for fluid electrolyte imbalance, monitoring nutritional status, and assessing improvement. That is, return of normal bowel sounds, decreased abdominal distension, subjective improvement in abdominal pain and tenderness, and passage of flatus or stool. The nurse reports discrepancies in intake and output, worsening of pain and abdominal distension, and increased nasogastric output must be reported. If the patient condition does not improve, the nurse prepares him for surgery. The exact nature of the surgery depends on the cause of the obstruction. Thank you.